Testing, testing. Testing, testing. Howdy! Hello everyone, Aaron Boster here, and I'm trying out some new things on my OBS software. I am super excited to jump online tonight, and I am looking forward to spending a couple hours with you doing an Ask Me Anything MS. So if you are new to the channel, my name's Aaron Boster. I'm an MS neurologist in sunny Columbus, Ohio, where it's not terribly sunny. And I am super thrilled to join you guys tonight to answer what's on your mind from an MS standpoint. I'm trying out a bunch of new stuff tonight. We've got the counter up in the, where is it? In the corner here. I'm kind of excited about that. There's 66 of you that have jumped online tonight already, which is really, really awesome. Thank you. I've got a bunch of music playing, and I don't know if you can hear it. Can you hear the music that's playing right now? Thank you, Jen. She loves the orange. Can you hear the music? Let's put this up there. You guys can't hear the music. Oh, darn. Okay, all right, that's a bummer. I was really, really excited about sharing some music with you tonight, which I can hear on this thing, but I guess it's not working. All right, so I'm going to have to try that another evening. Doug is on. Doug, I hope that you're doing well. He's one of our wonderful moderators. As you guys jump online, share with me where you're coming from, like where you're calling in from. I was really excited to share with you this background music, but I guess it didn't work. I can hear it, but you can't, so that's not so much fun. But nonetheless, let's jump into a Q&A, Ask Me Anything MS. So Julia has a question. She says, I have been on ocrelizumab. I have been in a wheelchair for 8 years. Would you believe possible for me to walk again? So that's a really, really intense question. MS Water Challenge, guys. When I drink, you drink. You know how it works. So Julia, first off, I don't have enough information. So the first thing I need to say is I can't accurately answer your question because I don't know enough details about your disease process and about you and about comorbid conditions and a bunch of other aspects. And so I can't really answer your question. If you have been using a wheelchair for 8 years, I'm going to make an assumption that you've needed it for quite some time. And I don't know why you've needed it. I have seen rare situations where someone has severe spasticity and their leg is like this, and we release the spasticity and they're able to stand up and do some ambulation. But I think it's really, really important that we never ever sell what I call false hope and say, oh yeah, for a limited time only, for $9.99, if you sign up now, then you can grow wings and fly, because I don't think that's really fair. Thank you for asking the question, and thank you for being on the live stream tonight. And I'm really sorry that you can't hear the music. It's really nice. One day I'm going to get it to work for you guys. Cheryl has a question. She says, is having extra sensitive feet common in MS? Yes, actually. So let me explain. So MS affects the brain and spinal cord. And the spinal cord is really interesting. So the area of the spinal cord that controls your arms is up here in your neck. And so if you have damage below your below that level, like so down in your chest, it can't affect your arms because of the way that you're wired. But it can't affect your legs. In fact, damage along any part of the spinal cord could result in leg problems. And so my point here is there's more surface area. There's more opportunity for damage to result in feet. And so because of the way the spinal cord is laid out, you're actually at higher risk of having difficulties with your feet more than you are with your hands. I'm so bummed. Guys, I set up different music for each scene. So as I switched from scene to scene, you were supposed to be enjoying different music. So I tried my best, but I'm going to try again sometime soon, and hopefully I can bring you guys some music. So right now you're stuck with my voice. So here's a question from Boston, from Cindy Leo. All right. Oh, that's not the right question. Oh, this is a question from Easy. Question from Boston. Can one have lower body symptoms, leg weakness, without spinal cord lesions? Yes, actually you can. And that has everything to do with the way the brain and the spinal cord are wired. So obviously the spinal cord controls certain aspects of movement, but the brain is the powerhouse. It's the computer that runs the spinal cord. And so there are areas of the brain that encode for legs, and there are areas of the brain that encode for arms, and so on and so forth. And so if you have damage to those areas, yes, you can have leg weakness in the absence of spinal cord symptoms. So here is a question from Cindy Leo, who writes, I heard they're trying to make an EBV vaccine, but what about the ones who already have EBV? Do you think that they are saying about EBV is the cause of MS? So that's a very, very appropriate question and a very timely question. So let me just set this up, EBV and MS. So I'll just throw that up in the chat. That's the topic of this question. EBV and multiple sclerosis. So let me share with you sort of what's been going on in the press recently that's so exciting, and talk to you a little bit about EBV and MS. So recently, like within a month ago, there was a really exciting paper that came out. And it was a research project where they looked at 10 million human beings in the United States, which is a lot of human beings. It's like a bunch of human beings. Hello, Lemon Peel, Angelfish, it's great to see you. I hope that you and yours are doing really, really well. So right now we're talking about the paper that just came out about a month ago, talking about how EBV and MS seem to be related. And in fact, they suggest that EBV may be one of the causal elements to develop MS. So they looked at 10,000 Americans, 10 million Americans, and they looked at a bunch of people without MS, and they looked at a bunch of people with MS. And they looked at their prevalence of EBV, like so whether they've had EBV. So what is EBV? Epstein-Barr virus. So it's a virus, the Epstein-Barr virus, which causes mononucleosis. Right? So mononucleosis, the kissing flu or the kissing disease, is extremely common. And when I say it's extremely common, I mean 95% or 97% of all humans that were tested in that 10 million person cohort had EBV. So the vast majority had EBV. But when they looked at the people impacted by MS, every single person except one had EBV. And so the thought process was that this is not by chance only. And the fact that essentially every single person with MS had EBV and only 95% of the general population had EBV, when you look at numbers the size of 10 million, kind of give credence to the fact that it's probably related. And that's not new information, believe it or not. So we believe that there's a genetic predisposition which predisposes an individual human to go on to develop MS. And it's not just genetic, like if you have it, you're going to give it to your kids, because it doesn't work like that. If you have MS, the risk to pass on to your children is actually about 1 in 40. And that's a genetic predisposition. And we then feel like there are environmental factors that can increase or decrease that risk. And those are things like exposure to secondhand smoke or firsthand smoke or low levels of vitamin D. We then think that you get a infection, you get a virus, and your body tries to fight off the virus, but your body messes up and it makes an error in judgment. And it identifies your brain and spinal cord as the EBV virus. And so for the rest of your life, as your immune cells float around your body looking for bad guys in specific EBV, they see your brain and they think they're looking at EBV, and so they attack it. And so that's the thought process. And this is not new information. When I was a fellow in training, like 100 years ago, we knew about this. And I actually had a mentor that wrote a book on it, a guy named Alex Sellis. And what's special about this most recent trial is not that they discovered it, it's that they kind of confirmed it using a really, really large cohort of patients. So that's wonderful that we have a stronger sense that EBV may lead to MS. But then it begs the question, so what? So what can we do with that information to help people impacted by MS, which is really the question that you were asking. You're basically saying like, so if somebody already has been exposed to EBV, what can we do? And right now, I don't think we know what to do. There's been a lot of discussions and theories, and some of them are really provocative. And so the one that's got me most excited is the following. Imagine that we developed a vaccine for EBV, which by the way is no small feat, and then we immunize a population of people. So maybe at birth, when you get your DTaP and your MMR and all the other required vaccines, we give you an EBV vaccine. And then we could see if over the subsequent 20 years, that cohort of human beings that were all immunized at birth went on to develop MS. And it's a really challenging study because, first of all, if we've learned anything from a global viral pandemic, COVID-19, a lot of people don't want to take a vaccine. And so getting the whole population to get vaccinated against EBV is probably going to be really tough. Now, maybe we would have a better chance, at least from a study standpoint, doing that in a socialized healthcare system like in Denmark or Sweden or Norway, where there's overall a smaller number of people, but more importantly, they're all tracked. It's all socialized. And so socialized healthcare has an advantage of being able to track all the people. And so maybe in a setting like that, you could immunize an entire generation of Finns or Swedes and then see if they go on to develop multiple sclerosis. So what do you do if you already have been exposed to EBV? Well, a vaccine's not going to help. And theoretically, if you invented a medicine that could go in and deplete EBV after you've been infected, that would be awesome sauce. I'm just not sure that exists yet. So that was an awesome question. Thank you. I also want to say thank you to 128 human beings that jumped online on spur of the moment on a Wednesday night to say hello, howdy, hi. Thank you. And I want to say thank you to all the people that view my videos on this channel who are going to watch this later. So if you're watching this right now with me, that's awesome. Throw a thumbs up in the chat and let me know that you're digging what we're doing. And if you're watching this after the fact, thank you for tuning in. And again, throw me a thumbs up and let me see some love and know that you dig what we're doing. Now, let's move on and take the next question. So this is Kelsey Davis writes, and she says, embarrassing question. Nerve loss in my lady bits. It's very hard to achieve orgasm. What options do I have? So Kelsey, for starters, thank you for bringing that up, right? So you are not the only person on this call that has that problem. It's actually very common in the setting of MS. And because it's a little bit socially awkward to talk about your lady bits, that may not be something that's discussed openly. But I'm telling you that it's very common. I know it's very common because I talk to 15, 20 families with MS every single day, and I hear about it again and again. So number one, thank you for being brave, and thank you for feeling confident and comfortable enough to say, hey, Aaron, I can't feel my lady bits, and it's really hard to achieve orgasm. And that stinks. Like, that's super not cool. MS Water Challenge. And so let's talk a little bit about what we can do to help. Whoops. Apparently I have a Snapchat filter on. Haha. Let's talk about what we can do to help with difficulty with the down theres. Now, for starters, Kelsey, I have several YouTube videos on this channel about improving sexual function in MS. And so if you haven't seen those yet, go on the channel, do a search for sexual function or difficulties in the bedroom. I've got several videos where I talk about tricks and tips to optimize sexual function. And that seems like a really good topic for a Wednesday night, so let's talk about it now. So when we talk about sexual dysfunction, I like to divide my thoughts. So first we talk about the first phase of sex, which is interest, like libido, like, ooh, you look sexy. So sometimes people have difficulties with libido. The second thing we look at is involving the mechanics of sex. So for a woman, that would be adequate vaginal lubrication. For a man, that would be erectile function, adequate for penetration. And then I look at orgasm, right? And those are all different, and they involve different aspects of the nervous system, believe it or not. So when we talk about those different phases of sex, I want to add a layer of complexity on top of it, because I want to talk about different kinds of sexual dysfunction. So there's primary, secondary, and tertiary sexual dysfunction, right? We're going to talk through all three. Primary sexual dysfunction is a situation where the circuitry of sex, like the wires that are involved in sex in your brain and spinal cord, are damaged from MS. And so it interferes with your brain learning what the down theres are doing, and then your brain helping the down theres complete what they're trying to pull off. And I'll use an example that I think helps clarify this point. Right now, as I talk to you, I am using an indoor voice. I'm in my house. It's really quiet here. The microphone is like 8 inches from my mouth, and I don't need to yell or scream. I can just speak normally. And presumably, you're just sitting wherever you are, listening on your speakers, and you don't have them like turned way up, or you're not like listening really carefully. You're just listening. And the reason that I can use an indoor voice is because there's no interference between my mouth, the microphone, the speaker, and your ear. If I had like my entire clinic team in here, all right, so a bunch of people yelling and screaming and talking and doing stuff, and it was very loud, if I used an indoor voice, you couldn't hear me, right? You wouldn't be able to hear. So I would have to scream really loud and use like overdrive voice to help you hear, to overcome the interference between my mouth and your ear. So the same thing can happen with primary sexual dysfunction, where there's damage to the brain or the spinal cord. And so when the down theres are stimulated, the message is going up the spinal cord and it dies. And so the brain does not know what's going on down there. It's not getting the memo. And that's primary sexual dysfunction. So what can you do about primary sexual dysfunction? You can buy a Hitachi magic wand. Let me write that down. Hitachi magic wand. Ooh, yeah. Now, I don't have a sponsorship by Hitachi. They're not sponsoring this video or paying me money. But if they wanted to, I would accept, because I love their product. A Hitachi Magic Wand is a back massager made in Japan, and it plugs into the wall. And it's got hardcore oomph to it. And what I would recommend that you do is that you buy a water-based lubricant, because it increases skin sensitivity. And then I would apply the Hitachi Magic Wand where it feels awesome. So that may be on the glans clitoris or elsewhere on the vulva. If you're a gentleman, it could be on the shaft of the penis, or it could be on the glans penis, or it could be underneath the testicles, anywhere that happens to feel good. And what it can do is it can provide overdrive stimulation. So it's very intense, and it's kind of the equivalent sexually of screaming, hello! So when you provide overdrive stimulation, hopefully the message gets all the way up from the down theres to the up theres, so that your brain knows, okay, I know the program, and then it can send a message back down for lubrication and for orgasm and all the good stuff. So my first suggestion is, if there's a suspicion of primary sexual dysfunction, is you want to buy a Hitachi Magic Wand. All right. Number 2. So the secondary sexual dysfunction is where you have symptoms which interfere with sex, and that's what you're talking about. And so you had said that your lady bits are numb, so you can't feel them very well. And that's a version, that's an example of secondary sexual dysfunction, where you're not able to feel as well as you could. And so what do you do about secondary sexual dysfunction? Well, ideally, what we want to do is we want to try to overcome the symptom. So if the symptom was bladder incontinence, then I would encourage you to catheterize before intercourse to empty your bladder. If the symptom was spasms, then we could take a stretching routine as part of foreplay. We could take baclofen and Xanaflex before we have intercourse. We could avoid positions where we're like doing the flying Luinda or something and causing spasms. So if the problem is decrease in sexual sensation or sensation, then the same recommendation about a water-based lubricant and using a plug-in-the-wall vibrator as overdrive stimulation, those are all very, very valid. I will also recommend Scream Cream. So Scream Cream is a compounded cream, and it's got medicines like theophylline and Viagra and things that force blood flow into the down theres. And so it's something that you can smear on your down theres on the vulva or the penis, etc., and you can increase blood flow and increase skin sensitivity. So there's a lot more that we could talk about as it relates to sex, but thank you very, very much. I just noticed that Desiree, one of our amazing moderators, is online. Thank you very much for joining us tonight, madam. Bluthton from Central New Jersey calls in with the question, if Lemtrada fails patients, what is your next line therapy? Very, very good question. And to highlight the good question, we'll change up the chat here. And before I answer that question, I want to put out a poll. Let me see if I can pull this off. Maybe I won't be able to pull it off. Let's take a look. Oh, I can. So let's do a little poll. I did a live stream with you guys like a couple days ago, and I asked if anyone wanted Snapchat filters, and we voted no. So would you enjoy Snapchat filters on this night's live stream? So let's ask you guys, do you want a Snapchat filter? So when I talk about a Snapchat filter, I'm talking about the silly things I can do like this, or let's see what else I can, or there's a bunch of things I can do, like this or like this, or I can look really cool like this, or I can become a cartoon character. So really what I'm asking is do we want to see some Snapchat filters tonight or not? So fill out that poll and let me know yay or nay, and then based on that, we'll decide if we do some Snapchat. So now to the question of if Lemtrada fails you, then what do you do? Now, first off, I love the way that Bluthton asked the question. So if you look at his question, he didn't say if you fail Lemtrada, because people don't fail drugs, drugs fail people. So I really like the way that he said the question. So first off, thank you for saying it that way. Second of all, we need to define failure, all right? So if you failed, or if Lemtrada failed you because of a side effect or a risk profile, you're probably going to leave Lemtrada and do something else. But if you had breakthrough disease activity, which is I assume what you're asking. So if you have a new attack, or if you have new spots on your MRI, or if you have progression of neurological disability, that's what I assume the question is asking. And if you've taken 2 courses of Lemtrada, so Lemtrada, as you remember, is an infusion in the vein. It's done for 5 days in a row. And then you wait a year, and then you do 3 days in a row. So that's the first course 5 days, the second course 3 days. And then you don't take it again unless you have new disease activity, which starts to answer Bluthton's question. So the first thing that we need to think about is if you've had 2 courses and you have breakthrough, then we need to think about what do we do next. Options are do nothing, which is not my style, give a 3rd course of Lemtrada, or switch drugs. Now, as I mentioned, I'm not going to choose do nothing because you had breakthrough disease and I'm not okay with that. So I'm going to talk to you about a 3rd course of Lemtrada or something different. And if you had breakthrough after 2 courses of Lemtrada, but otherwise your disease has been really stable, and in many ways maybe things are going better, you may choose to take a 3rd course of Lemtrada. Now, in reality, when you look at the clinical trials, we have 10 years worth of data, which is a lot of data, and about 55% of people never got another round after the first 2. So they took the 5 days, They waited a year, they took the 3 days, and then after the first 2 courses, they never had anything else. So 55% of people went out 10 years and had nada, just the first 2 courses. 30% of people got a 3rd round. All right, so 30% of people had breakthrough, meaning they had 2 spots on their MRI, or they had a new MS attack clinically, and they got a 3rd course of Lemtrada. 14% got a 4th course. Now, in my experience, when someone has breakthrough on Lemtrada, if they have had a relatively good run of it, I am comfortable giving them a 3rd and even a 4th course. I have not in my practice ever gone beyond 4 courses. And so one option is to simply take another course of Lemtrada, which I would recommend. Another consideration, if you don't want to do that, is to switch. And whereas I don't think any of the MS medicines in groups are as effective as Lemtrada, you're not a groups, you're an individual human being. And if you've had breakthrough on Lemtrada, Lemtrada is not working as well for you as we had hoped. And I think that opens up the doors to think about a lot of different things. And probably the drug that I reach for next is Ocrevus. And so I think when people have had breakthrough on Lemtrada or Lemtrada has failed them, so to speak, and we're looking for something different, that's most commonly what I'm switching to. So that was a really good question, and thank you for asking it. So our poll is ongoing, and right now, 48% would like Snapchat filters, and 52% would not. Now, it's really close, and so if you haven't voted, your vote really, really counts. So please take a moment and throw up your answer. All right, so with that stated, I'm looking around for some more questions. Here's a question from Courtney Sanders, and she writes, numbness and tingling be felt in your back, in the back of your head. I get that from time to time, and I'm not sure if it's a symptom or not. So you bring up a really good point, Courtney. Human beings do not have rule books, like where they look up like what's going on. And they don't have a manual. Like there's no manual for your body. And so you don't know exactly what's happening. You just know that something's happening. So you feel numbness, and that's really probably a very awkward feeling. And could it be from MS? The answer is yes, it could be from MS. And in fact, numbness is a very common symptom in MS. Now, it doesn't mean that it's the only option, but if you have multiple sclerosis and you have a new numbness, the first thing I'm going to think about is, are we having breakthrough disease? Is your disease active? So thank you for asking that question. All right, I'm searching around for other questions. Got a lot of thumbs up, guys. I love that. Thank you. Desiree loves the Lady Bits questions. So do I. So let's take a moment and flame up the chat. Flame up the chat. So if you would be kind enough to go ahead and just flame up the chat for me, it lets the YouTube algorithm know that you're enjoying what we're doing. It makes me feel like super awesome. So if you don't mind, go ahead and flame up the chat for me, guys. It would mean a lot to me. I would really, really enjoy it. Once we get that chat all flamed up, I'm going to jump into answering yet another question. Oh, we've got some awesome flames going on. You guys are amazing. Ben is flaming it up, and Sauna's flaming it up, and Christine is flaming it up, and Ashley is asking a question, but Christy is flaming it up, and this is fantastic. Jen McGraw is flaming it up. Karen Tweed is in the house flaming it up. You guys are wonderful. Thank you very, very much. That's super awesome. I really appreciate you doing that. It's really fun, and it's fun to look at. Masson came up with some really fun stuff from Canada there. I love that. Okay, thank you, guys. That's really, really cool. Thank you for the flames. So this is a really good question. Rennie Berry asks a super good question. How do you find a PCP who is friendly to MS? All right. So, or is friendly to MS knowledge. So how do you do that? So the reality is that being a primary care doctor is arguably one of the hardest subfields in medicine. A primary care doctor needs to know something about everything. And that's a lot. So I'm an MS subspecialist. So whoops, sorry guys. I did not mean to click that. And whoops, I'm doing a bad job here. So I'm just going to throw up some flames while I answer your question. How do you find a good primary care doctor that is friendly with MS information or whatnot? And I was saying that it's really, really hard to be a primary care doctor. There's the question. Because you have to know about the heart and the lungs and the skin and the kidneys and the bladder and the liver and all of the things. And I read every single day about my field. but I read about one topic. I read about multiple sclerosis, whereas a primary care doctor needs to kind of know a little bit about everything. And that's a really, really hard job. And it's not uncommon that a primary care doctor, particularly a family medicine doctor, might not know a lot about multiple sclerosis. They may not have any patients with MS, or they may not have very many. And so this is a very commonly asked question. And so a couple things that you can do. One thing is that you can ask your friends in your support group who's their PCP, and do they have a PCP that is MS-friendly? So that's one way you might do it. You might find a primary care doctor that's associated with a large academic center. Sometimes those academic folks are more up to date, but also they're going to have colleagues that work with them that are neurologists. And so when they're in their lunch hour at the cafeteria, they can ask questions, and it's kind of a more collegiate academic kind of thing. You could talk to the doctor and you could ask them, say, hey, I have MS. I don't expect you to know a lot about MS, but how comfortable are you with it? And what is your comfort level in helping me? And then just see what they say. And if they're like, then maybe you need to find a different doctor. But if they say, absolutely. I have a lot of primary care doctors who will openly admit that it's not their area. They don't know a lot about it, but they want to be helpful and they're willing to collaborate with me. And I think that's awesome. You want to make sure that your neurologist is sending all of the correspondence to the primary care doctor. And if there's certain things that the neurologist needs from the primary care doctor, that shouldn't come from you, the patient, that should come from the neurologist directly to the PCP, like through a formal letter or something like that, or communication, telephone, whatnot. Now, sometimes you can find a PCP that really wants to be supportive, and that's such an amazing thing. And if you find that, hold on to them and don't let go. And I want them to become a really big team member. I think at the end of the day, Ren, it has everything to do with communication. It has everything to do with saying, hey, I got this condition. How comfortable are you? Be honest with me. If you're not comfortable, that's okay. Can we work through this together? Will you work with my neurologist? Will you call my neurologist? If we need to admit you in the hospital, will you help admit me in the hospital? Those kind of things. So I really think it comes down to, in part, that. Now, there's other things. So in previous jobs, I ran CME courses where once a year I would put on a big CME. And CME stands for Continuing Medical Education, where we would prepare lectures and we would bring in doctors and nurses and physical therapists and occupational therapists. And we would do a day-long seminar. Sometimes it was a 2-day seminar where we would up their game and talk about what's new and hot in the setting of MS. And it was intended to target primary care doctors sometimes. We would want to up their game and help them understand and make them feel empowered team members. So that's something you can do. The bottom line is that we need a team to take care of you. I thought when I was a munchkin coming up through the ranks that I could be the everything doctor for someone with MS, meaning I could do all the things for that one human, all the heart and the lung and the diabetes and the this and that. And the reality is that I was very, very naive. And I didn't realize that medicine's really, really involved and complex. And I spend, as I mentioned, all of my time staying up to date with only one disease process, with multiple sclerosis. And so because of that, I am grateful that a primary care doctor is in the mix. In fact, at the Boster Center for MS, you're not allowed to be a patient unless you have a primary care doctor. I take care of a lot of people that don't live in Ohio, they live elsewhere, and they need a primary care doctor in that state, in that city. And so if we need to admit you in the hospital, they can help. If we need to prescribe a controlled substance, they can help. Now, let's talk about some things that primary care doctors can do to really help up your game, because there are certain things that are very, very valuable, right? So number one, the biggest thing that I think a primary care doctor can do to help me help you is to focus on your health maintenance outside of MS, right? So making sure that you're up to date with your cancer screening. When it's the time for the mammogram, you get the mammogram. When you're of the age of the colonoscopy, whoop, you get the colonoscopy. You get your skin checked once a year. You get your thyroid checked. So those kind of things. If it's appropriate to get an EKG, then you get an EKG. If it's appropriate to get a PSA to screen for your prostate, then you get a PSA. And so seeing the primary care doctor to focus on that is super helpful, because that's not stuff that I'm up to date on. That's not stuff that I'm doing routinely. The second thing is checking laboratories. Now, you may see your PCP more often than you see the neurologist. And if that's true, and if the neurologist has you on any of the MS medicines except Copaxone, there are labs that need to be checked. And so it might be more convenient for you to have those labs checked at your primary care doctor's office than at your neurologist's office. And as long as they're sharing back and forth the info, I think it's cool in the gang. And so having the PCP help in that regard is very, very helpful. What else can be helpful? Well, very commonly, someone with MS can develop new neurological symptoms. I saw that probably 4 or 5 times today. And the very first thing that we're going to do is we're going to check a urinalysis, because it's more likely that they have a urinary tract infection than they have a new MS attack. And so if they have a UTI, then we treat the UTI with antibiotics. Now, primary care can be super helpful because a lot of them are set up where they can bring you in and quickly do a urine dipstick. They can look at it, they can tell you what's up, they can give you an antibiotic. And so the primary care doctor screening for infection in that regard is extremely helpful. What else? Well, people impacted by MS that are over the age of 50, are at increased risk of thinning bones. And it's appropriate after the age of 50 that both men and women with MS, independent from whether they receive steroids, have a bone density test, a DEXA bone density scan, which helps determine the thickness of their bones. And if their bones are really, really thin, then we can give them medicines to beef up the bones. Now, the primary care doctor could help us a lot by ordering those tests. People impacted by MS are twice as likely to experience depression compared to the general population. They're also twice as likely to experience anxiety compared to the general population. Primary care doctors are the psychiatrists of today, and they're very, very good at managing mood. And so they may be able to help you in dealing with some issues with depression and anxiety. What else? Low levels of vitamin D drive MS faster. And so a primary care doctor can check your vitamin D 25-OH level. And if it's below 50, then they can help give you supplementation. So there's a host of things that primary care doctors can do to collaborate with the MS neurologist to up your game and help you live your best life. That was a great question. Thank you for asking. So we have finished let's finish the poll. So I asked, would you enjoy some Snapchat filters on tonight's live stream? And 53% said no. And so we're going to go with the majority, and we are not going to use Snapchat filters tonight. I want to be respectful, and if you guys don't dig it, then we ain't going to do it. And so thank you for participating. 152 of you answered, which is a good majority of the people that are on the call right now, and that's really, really awesome. So here's a question from Judy Sherry, who writes, can lesions in the spinal cord cause intractable migraines? If so, what's the best course of treatment? So I am not familiar with spinal cord lesions causing migraines. So we don't typically think of cord lesions causing migraines. Now, you can have what's called cervicogenic headaches. Cervico is a reference to the neck. Cervicogenic means that's where it comes from. So cervicogenic migraines are headaches that are caused by a problem in the neck. And a lot of times that's managed with injections, not in the spine, but in the back of the head. So you do bring up an interesting point that when there's damage to the skin, our body is constructed so that we know exactly where it occurred. So if I was damaged to my skin, I can close my eyes and point exactly to where I was injured. When you have damage to the brain and spinal cord, our brains are not wired to be able to sense that. And so oftentimes we have unusual or referred pain, which is really strange. That was a really good question. Thank you. Can I reflect that there's 180 people on a Wednesday at almost 9 o'clock Eastern Standard Time? Thank you, each and every one of you. That's really, really awesome. It's so cool that there's this growing global online community that supports each other and supports me. I want to thank you guys for that. And if you're watching this after the fact on the replay, thank you for watching the replay, and definitely leave me a comment in the section below. Tell me where you're calling in from, and if you have a question, shout it out. Here's a question from Courtney Sanders, who writes, question from Michigan. Can an infection cause worsening or new symptoms? Can it cause a relapse? Yes and yes. Yes to both. So if you have an infection, your immune system fights the infection, except in the setting of MS, your immune system is overly active. And so sometimes in the setting of an infection, when your core body temperature is raised, it causes you to short circuit parts of your nervous system, and you can have old neurological injuries that come back out to visit you. That's called a pseudo attack or a pseudo exacerbation. And it's very, very common. I see it, unfortunately, probably about several times a day, once or twice a day, in the setting of patients that contract COVID. And in the setting of a really, really yucky febrile illness, they have all kinds of neurological symptoms that come back out. Now, the second part of your question is, could an infection trigger an attack? And the answer is yes. An infection can trigger an attack. It doesn't always, but it can. And if you have an infection with a pseudo-exacerbation, meaning you have a reemergence of old symptoms because of the infection, we give antibiotics to make it go away. Sometimes we give antibiotics and the infection goes away and the neurological status is getting worse. They're having an attack triggered by the infection. And then we also give steroids. Very, very good question. Thank you for asking it. So Mia Brickner, asks, are there any treatments for disequilibrium imbalance? Good question. So I have a couple videos on this channel about balance in MS. And so Mia, if you haven't checked those out, definitely please take a look at my videos I made on balance. You also may look at my videos I made on walking because they kind of talk about that. There isn't a pill for that ill. You can't swallow a pill for balance and then have it work. I wish you could. That would be like super awesome. But you can improve balance through physical therapy. So NeuroPT is the bomb.com for improving balance. And they can give you all kinds of exercises to help you with balance. So in the spirit of that, let's see if I can show you a couple balance exercises today. I'm trying to figure out where I can stand up. Let me move some things around on the screen. Bear with me. I'm going to move this question down here. And so I'm going to try to go over in the corner there, and I'm going to demonstrate some balance exercises. So what you're going to see me do is go over in the corner, and I'm going to stand at attention. I'm going to put my hands and feet together, and I'm going to demonstrate how I go in the corner of the wall, in the corner over there, and put a chair in front of me. And that's how I want you to practice your balance exercises. So I'm going to show you the setup, and then I'll come back and talk to you. So hopefully you can still hear me, and my dog and cat can hear me. And I'm over here in the corner. Hey, I've got this chair here. And so I'm in the corner, and that way, if I fall, I'm falling in the corner. And as long as I don't catch myself on fire, all is well. Now I've got this chair here, so now I feel really safe. So I'm in my house, but my environment is such that I can't fall and hurt myself. So what I'm going to do is I'm going to bring my feet together and my hands at my sides, but I can grab this if I need to. And I'm going to practice closing my eyes. And then I'm going to open my eyes. My feet are together. I'm going to close my eyes and open my eyes. Now there's a host of things like this that you can do where you change your feet position or you go on one leg. So now I'm balancing on one leg and closing my eyes. You can even put your feet like this, etc. So that's a way that you can check out some balance type stuff. And if you would like to see a bit more of that, please check out my videos on balance. Thank you for that question. Now, there are 195 people online tonight, and I think that's the most that we've ever seen on this channel. That's amazing. And it kind of begs the question, could we get to 200? So I don't know how you get to 200, but maybe we'll just cross our fingers and hope that a couple more people jump online. That would be like a new record. So here's a question from Mike. And Mike says, I'm my wife's caregiver. She was diagnosed in 2014 and has primary progressive MS. She has chronic fatigue syndrome and optic neuritis. As the years progressed, the neurologists seem to be saying most people with MS really don't. Wait, I'm trying to see the rest of your question. And then the question cuts out. Oh no, I'm so sorry. So I don't know the end of the question. I feel like I don't know the end of the story. So if you can post your question again, I'll look for it, and then maybe we can try to answer the full question. I'm sorry about that. So here's Michelle L. that writes, question from California. Can steroids help for non-active lesions? So that's an interesting question. So when you have a enhancing lesion that lights up with contrast, it's because of active inflammation in the now, at the time that we're looking at the scan, and there's breakdown of the blood-brain barrier, and so the dye that you're putting in the vein leaks out of the blood vessel into the brain. And so for about a week to 2 weeks, maybe up to a month, it lights up. And if you give steroids, it closes the blood-brain barrier and it slows the inflammation and quells the enhancement. It makes the enhancement go away. This question is about a non-active lesion. And generally speaking, we don't think about steroids as helping non-active lesions. Now, you could have a nerdy discussion about whether they're doing something in the background to quell the overall milieu, but I generally, if I see a T2, a bright spot with no enhancement, I give steroids and it doesn't change very much. And I have to be honest with you guys, I'm sitting here staring at the count because it's 199. And so if one more nice human being jumps on, we'll have set a record. Oh, and that just dropped a lot. So maybe talking about it made people flee. Now there's only 189. I'll stop looking at it. Trollhawk has a question. I have a medium-sized tattoo years ago. I had an attack shortly thereafter. Question, can the recovery from a tattoo cause a flare-up? So, Troll, that's a good question. To my knowledge, no. So to my knowledge, getting a tattoo should not trigger an attack. If the tattoo was extremely invasive and caused a massive skin infection, which would be very, very unusual, then maybe it could trigger an attack, but I would not generally think of a tattoo triggering an attack. Now, as my homework tonight, I'm going to look up tattoos and MS and see if there's ever been reported cases, but to my knowledge, no. And thank you for asking that question. If you guys like what we're doing, do me a favor and throw some flames in the chat. We might not be able to get 200 people online, but let's see if we can flame up the chat. So go ahead and throw some flames in the chat. Show me some love. Let me know you like what we're doing here, and then I'll keep on keeping on with the questions. And Alex Johnson is hooking it up. Stephanie says, please share the video so we can get 200. Thank you, Stephanie. So we've got Morris that's using some flame action and some love there. We've got Ben showing some love. Jay Stevenson's showing some love. We got Belspic that's showing some love. This is fantastic. Thank you, guys. Thank you for all the flames. We might not get to 200 tonight, but we're going to have a very toasty, flamey chat. And I think that's super awesome. So let's go on with some more questions. All righty. Let's see here. Oh, you guys are awesome. You guys are so fun. Thank you. It's really, really awesome. Thank you, Brad. So here's a question from Steph. Had a bad lesion on my brainstem, no longer active. I just was wondering how it can affect driving. I couldn't drive for months and lost the grip strength in both my hands. Now, and then it cuts out again. So driving is a really, really complex task, right? I mean, you have to be scanning your environment and you have to be using both your feet if you drive a manual or one foot if you don't, and you have to be driving with your hands and you have to do the turn signals and you got to adjust the radio. And I'm not being silly. I mean, it's a very, very complex task. There's a bunch of stuff that needs to go on when you're talking about driving. And you could have difficulties with driving in the setting of MS from like 100 different reasons. So if your depth perception was off, if you had double vision, that could impact your ability to drive. If you had cognitive fatigue and it was hard to make quick decisions under pressure. If you, as you point out, if your grip strength wasn't good, or if you couldn't feel your hand, or if your foot was ataxic and kind of bouncing around, or if you had spasms of your leg, there's a host of things that can interfere with driving. Now, in the United States, and particularly, oh my gosh, we did it, 203, woohoo! So let's do a happy dance. That's awesome. Yay. Thank you, guys. How fun is that? Woohoo! Sorry. That was really, really neat. I've been doing this YouTube thing since 2015. I've never had a live stream with this many people. Thank you very, very much, guys. Woohoo! 200. So if you are having difficulty with driving, it's a complex task, and there's a solution to try to unravel it. And that's to use occupational therapy driving evaluations. So occupational therapists are awesome people. They're wizards that are helpful in figuring out how to help you do your activities of daily living. Brushing your teeth, combing your hair, putting your pants on, driving your car, typing on a computer, activities of daily living. This is the kind of stuff that they are really, really experts at. And specifically as it relates to driving evaluations, they can help you with driving. And so if you're struggling with driving, or if you're uncomfortable or concerned, then you can ask your neurologist to refer you to a occupational therapy OT driving evaluation. So an OT driving evaluation, they literally will put you in a car, like together, and you'll drive around. And they can help you figure out how to drive safely. These are the folks that can help you with hand controls for your car. And they're the folks that can teach you how to drive with your other leg or all those kind of things. So it's very, very valuable. And I've settled many marital debates where the person with MS feels that they're safe to drive and the spouse says, nuh-uh. And so we go to a driving evaluation and they're proved to be safe or not. And it can be very, very helpful. So Sarah Woods writes in, what causes our bodies not to regulate temperature correctly? So unfortunately, Sarah, your brain is the thermostat and the temperature gauge. And in the setting of MS, it can get messed up. Also, in the setting of MS, if you get overheated, you can short circuit. So not so much the temperature gauge, but as your core body temperature raises, like let's say you live in Florida and it's freaking hot outside and your core body temperature raises, it can short circuit your spinal cord and brain and where the lesions are and cause old injuries to come back out. So let's look for another question. There's a bunch of them on here. So Lemon Peel Angelfish says, OTs are awesome. Yes, they are. OTs are absolutely awesome. It's very, very important to know a couple really good OTs. And Tina is in agreement. Now, here's a question from Wolerna. I'm sorry, I'm not saying your name correctly. Wolerna. So if I said that wrong, I apologize. So Wolerna says, question from Laura, I can say that, in England. Is wearing a nicotine patch during a Tysabri infusion safe? Would it undermine it? That is a cool question. And I don't think that we know the answer, but we do know some stuff. So I shared on this channel a really, really bothersome paper that I read, which demonstrated that people with MS who are on Tysabri and who smoke, it increases the risk of attack substantially. So people on Tysabri who smoke are going to have way more attacks than people on Tysabri that don't smoke. And the data was like scary. It was very, very clear that smoking markedly decreased the efficacy of one of the most effective drugs, Tysabri. Very bothersome. And so that's evidence, if I've ever seen it, of someone benefiting from not smoking. Now, your question is different because it's not asking about smoking an analog cigarette, it's about a nicotine patch. And the thing is, I don't know whether or not it's so much the concern of nicotine as it is sucking in carbon-based smoke, which is so pro-inflammatory. And so if I had to pick between a nicotine patch in an effort to get off of smoking cigarettes or not, I think I would be okay with the nicotine patch. I'm not familiar of, as I mentioned, any data that says it will make the Tysabri not work. I just want to stress that smoking cigarettes is really, really pro-inflammatory and it speeds up MS by almost 50%. And so anything that you're going to do towards getting away from cigarettes is a really, really good idea. And I would most certainly rather you have a nicotine patch and not try to smoke than I would the opposite. The good question. Thank you for that. So here, Latricia writes, tested positive for the JC virus, currently on Vumerity for almost 2 years, have 0 side effects. Should I be worried? No. There's one weird caveat where you might want to be worried. Oh, wow, there's 206 people again. Thank you, guys. So if you are on Vumerity, Vumerity has no bearing on PML unless Vumerity by accident has caused you to be immunosuppressed. So the diroximel fumarate, Vumerity, and dimethylfumarate, Tecfidera, are both fumaric ester salts. That's the compounds. And they both work by this really cool NRF2 pathway. But about 20% of people that take these medicines end up with dropping their white count, even though they're not supposed to drop their white count. Now, if you drop your white count on Vumerity, you are at slight increased risk of PML, and your MS neurologist should be able to talk about the risk profile because there's only been like 11 patients total with Tecfidera that developed PML to my knowledge, and all of them had a white count that was below 600, the lymphocyte count. So I think that there's a very, very, very low likelihood of concern. So Kelly Williams poses a question. Multiple lesions almost covering my entire cervical spine. does that make me more predisposed to become a quadriplegic in the future? Well, that's a rough question. And the way that you asked it, like, it makes me feel it's intense. And the answer is yes. But I want to describe it a little bit. So if you have a spinal cord lesion, it does not mean that you're going to end up not able to move your arms and legs. That is not what it means. But it does mean that you're at increased risk of problems with arms and legs moving in the future. And so when I see someone that has spinal cord lesions, I can't undo the spinal cord lesions, but it tells me this person has very, very aggressive disease and I need to come out of the box swinging. All right, I need to bring a SWAT team to a knife fight. I need to keep them in ship shape because as they age and as their spinal cord ages and as those lesions wear out, we risk having serious difficulties. And so I need to do everything under the sun to allow the spinal cord to age naturally and to prevent any further damage from occurring. That was a really intense question. So I can't believe there's over 200 people. This is so cool. Now, Lemon Peel Angelfish just did like the nicest thing. This is like a super chat. And just, that was so generous. Thank you so very, very much. God, that's amazing. And she writes, Dr. Boster, you're so awesome. Well, you know what? You're awesome also. And it's an honor and a privilege that we get to share this community. It means the world to me, to be honest with you, that we can get together and we can talk in this manner. It's really, really cool. All right, let's look for another question. So here's a great question. Can we assume the following? The current available DMTs, we are able to extend the period of transition from RRMS to SPMS. So yes, so disease-modifying therapies delay onset of secondary progressive MS, particularly the newer high-efficacy therapies. And this has been studied with Lemtrada, it's been studied with ocrelizumab, it's been studied with a lot of high-efficacy drugs and found to delay onset of secondary progressive MS. Yes, yes, yes. Moreover, anecdotally, if you talk to an MS neurologist who remembers the era of no treatment and ask them what their waiting room looked like compared to now, they'll probably tell you that it looks really, really different because in the era of no treatment, a lot of people unfortunately came in wheelchairs and gurneys, and now we don't see that very much at all. So Cynthia writes in, Aaron, thank you for the Dopamax video. I noticed my word finding problems today. So Cynthia is referencing a video I made talking about cognitive difficulties from various medicines. And I was talking about one of the medicines, Topamax, topiramate, which is a really great medicine for seizures, and it's a great medicine for pain, but it can sometimes cause cognitive impairment. And the joke is that it's nicknamed Dopamax, just to remind you of that. MS Water Challenge. It is 9:07. I jumped online spontaneously because I was trying to create background music. So I have background music playing, which I can hear in my headset, but you can't hear. So that's a real bummer because I was really excited. I chose different songs for each scene and, I'm not going to quit my day job as a neurologist, but I'm going to keep learning on the interwebs. And hopefully the next time we get together, then I can play some background music for you. Nonetheless, 223 human beings were kind enough to jump online and spend a little bit of their evening with me, and that means the world to me. I am absolutely full of gratitude. Thank each and every one of you, and thank you to all the awesome sauce people that are watching this after the fact in the replay. My name's Aaron Boster, and as always, thank you so much for learning about MS with me. I put out a video every Monday. This past Monday, 3 days ago, I put out a really big video. It took me a lot of effort and a lot of thought, and I really hope you like it. It's on diet and MS. Every Thursday, I've been putting out a short form video just for fun, and I've been learning this online software, this OBS stuff, and really digging it. I try to do a live stream at least once a month. My big live stream for this month is going to occur next Thursday. So it's going to be a giant live stream. I have some really exciting guests coming on. I have a doctor researcher who's going to be sharing about some really cool research for children with MS. I've got a group called Total Fitness, and they're going to launch MS fitness program that we've been working on behind the scenes called Total MS. I'm super, super excited about that. And if things go well, then when you're on the call, then you'll be able to hear the background music the way I can right now. Until my next video or my next live stream, I am completely and utterly blown away that 222 of you got online with me tonight. God bless each and every one of you. And until my next video or my next live stream or the next time I see you at the Boster Center for MS, this is Aaron Boster saying have a super awesome night, be safe, and take care, guys.